Halima Begum from the Runnymede Trust. I have Marie Gabriel from the NHS Health and Race Observatory. I have Parth Patel, a junior doctor and research fellow at the Institute of Public Policy and Research. I also have Chand Nagpal, GP and chair of the British Medical Association. Thank you all for joining me today in today's panel discussion. I want to kick off with something positive. When we talk about this discussion or when we talk about this topic, we tend to go off and talk about some of the negative things and we get caught up in this negative atmosphere. So I want to know between ourselves, we have decades of work that we've done in the realms of race equality. But what progress do you think we've made over the years since you've started to work in this, in and around this issue? Halima, should we start with you?
Yeah, why not? Thank you. It's a real pleasure to be on this panel with such great guests who've had vast amounts of experience in this field. So thank you for having us. So I think we normally say there's been some progress, but also reversals. But I will stick with the progress because we want to think about the glass being half full, not empty. Certainly in my lifetime, I'm about 46 now. I have seen a lot of progress in terms of understanding a little bit more around the kind of differences within our communities and the kind of barriers that we face. So certainly growing up 16 or 17 in the East End of London, for example, and being very comfortable in my skin and feeling as though, oh, I don't need to code switch in any way. All of that, I think, has got easier. So a lot of us feel much more comfortable in our skin to talk about the issues that matter to us and to try and create a common understanding around the barriers that we face in housing or health and just by being a minority. So I think at the public framing level, there has been a lot of progress. But there have also been setbacks, as you know, Jahangir, and more recently, those setbacks were such that I think the whole world, when we watched, George Floyd being murdered in public glare across the world through a social media lens, it was quite shocking still to see, my God, did that actually happen in 2020? And I think although there was progress, I mean, all of us had collective trauma together. I think even the white racists probably had collective trauma when they saw that murder take place. And I think that caused us all to think, in that kind of zeitgeist way, how is that even possible? So yes, there's been progress, but I think we've all been shaken to the core. And for the first time in my lifetime, I feel like it's not just safe, but it's okay to be bold. It's okay to be upset. It's okay to show how upset I am that this can happen and does happen, and to actually seek out for some allyship and to ask for that help to try and make sure that when our children grow up, that never, ever happens again. That is progress because it's on the back of a lot of pain, but this is progress. When you can see how bad things are and everybody feels the pain, I think we can now try and think about redesigning society in a more equal way. So that is progress to me.
Anyone else want to get going, Parth?
Yeah, so I'll agree with you. I can't quite hark back to sort of a longer period of time, sort of by virtue of my age. But what I can say is that 2020 does feel like it's a real moment of progression for racial justice within healthcare and sort of the bigger picture. So the combustible atmosphere, the protests of the Black Lives Movement, combined with the so visibly unequal effects of the pandemic, have sort of synergized in a way to create a real appetite for change. And there is reconstruction of social structures. There are ways in which the health services are being redesigned and rebuilt. And within that, there is an opportunity now to explicitly try and address racial disparities. So I guess what I'm saying is perhaps that there's a moment of progress here, and it's for us to now to try and grasp.
I mean, I would agree with that, definitely with what both of you have been saying. I think there's something a bit more for me in that it's also changed the narrative. So I think the big change that I'm seeing currently is that previously there was quite a deficit approach. I'm just thinking about your audience of healthcare leaders. They would have, they would have all, from BME backgrounds, they would have understood that we've always had to try that bit harder, that to enable the equality to be achieved, we had to have more training, more development, more enablement, although there was a deficit within us. Definitely, I think with the Black Lives Movement, that narrative have changed to us saying, actually, it is structural racism. It is not that there's something within us. It's actually the way in which society is organised, societal ideology, which is preventing us from progressing. And I think that as healthcare leaders, what every healthcare leader should be doing now is saying to themselves, what is it? What more must I do to eradicate structural racism within my sphere, whether that's in my team, within my organisation, within my clinical practice, within the health outcomes that my patients and services experience. I think that change in narrative shifts the burden of responsibility away from us in terms of to those that need to be held to account, not to say that we need to escape from continuing to fight. I think the only other thing I want to say is probably about the Workplace Race Equality Scheme, which produces information every year in terms of the NHS workforce, and it's a growing number of staff of Black minority ethnic backgrounds, and it's approximately 1 in 5 or just under that, and there is progress. It shows that if you have intent and if you have effective leadership, you can, even though we're a product as a health leaders of our society, with its concerted effort, you can create change.
Okay, so thank you, Jingy. So from my end, I came to this country when I was 7, but I was schooled here from that age onwards, and went to a London university to train in medicine. And I think for me, the first time I mean, talk about progress, well, I experienced something I don't hope would not be happening now, which was back in 1986. When I applied for GP training schemes, I was actually quite shocked that, and actually quite upset and demoralized that I had 9 rejections in a row without even being called for interview. And it hadn't even dawned on me that there was anything racial about this until I asked my GP tutor, and he said, "It's your name." And I have to say, it just shook me. I couldn't believe that, having been schooled here, I'd done very well, that something like this could have been an impediment. And sure enough, for the 10th application, I went to Charing Cross Hospital, where I applied for their training scheme for general practice. And I actually knocked on the door of the postgraduate dean and said, I'm applying for your training scheme. I want you to know who I am, what my name is. Here's my CV. Just remember me when you see the application formally. I was shortlisted, and I was offered a position with a competition of 180 applicants for 2 places. But gosh, I had to prepare for that like I was preparing for an A-level, because I had to really show that I knew more than absolutely anyone else who could possibly have entered that interview panel. So that was my first experience. Now, I would like to hope there's progress, that the system in which people are shortlisted isn't based upon their name. It was only years later I came across Sam Everington and Anis Ismail's seminal research that showed that the name on a CV makes a big difference in whether you're shortlisted. But that was my experience. The other experience that worked in my favor, but again, it shows the discrimination, was when I applied for my GP partnership, and I was offered the post. I was 1 out of 80 applicants, and when I asked the 2 GPs who offered me the post, how did you select me out of 80 applicants? And they said it was actually quite easy. The shortlist was much smaller because all the doctors who had graduated overseas were put into a different pile and weren't going to be shortlisted. And on this occasion, it worked in my favor because I was trained here. Now, I would hope that sort of blatant discriminatory ways of shortlisting aren't quite as the reality now. So in that sense, I hope we've made progress in those mechanistic terms. In terms of BMA, here I am, chair of the BMA Council. But, you know, when I first was elected onto the BMA's GPs committee back in 1996, it wasn't quite like it is now. There wasn't the diversity in front of my eyes, at least. We used to have one member representing overseas doctors on our committee. I was the very first non-white to be on the executive of the GPs committee, the very first non-white to chair the GPs committee, and I'm the first non-white to be an officer and chair of BMA Council. Now, in the time that I've been at the BMA, of course, things have changed. I'm seeing much more diversity. Jingy, you're on our BMA Council. I'm seeing other BAME doctors heading and chairing committees. So in that sense, we've seen progress. However, I think what we have also seen is that racism has manifested itself in different ways. So we've tackled it in some instances. We're showing improvement, but it's coming out in different ways. Some of it is more covert. Some of it is manifest in different ways. And I think the other thing that has really made a difference, and what we have now, is unequivocal data. So back in those days, when I didn't get my interview, there was no data I could call upon. You know, Sam's work was seminal. Marie has just talked about the race observatory. Data has absolutely shown that no one can argue about the inequalities, the race inequalities. I mean, no one can. And the experience that we heard earlier from Halima about the killing of George Floyd, well, you know, that isn't a US issue. That just shows that society has really, you know, it hit you barefaced that we really do have there's really a consciousness that is wrong in some parts of society, and there's also at the same time what I think is progress is a determination and commitment. When I've seen the response to the Black Lives Matter movement, when I've seen the response to the COVID disparities, we are at a pivotal moment that we've got to seize, which is this collective determination now to go beyond the surface of the issues and really tackle, root down, the need to have a fair and inclusive society. So that, I think, is progress, but we need to deliver in the months and years to come.
Thank you, Chand. So between us, I know we tackle race equality in various aspects. So Halima, you're director of a race equality think tank, Runnymede Trust. And you've collaborated with Path at the Institute of Public Policy Research recently, and you highlighted some of the inequalities in terms of race and socioeconomic differences when it came to the second wave of the pandemic. But I want to ask what you guys think has changed between the first wave and the inequalities highlighted then to what's happening now. Has policy changed? Have the government take on initiatives, or what's happening on grassroots level, both in terms of patient experience and then the experience of healthcare staff? So that goes to everyone on the panel, including Marie and Chand. So Halima, Path, do you want to start? Carry on, Path.
Okay. Yeah, so the IPPR and Runnymede Trust did some research early this year looking at tackling this problem exactly. And our perspective is that what happened in the first wave is that we saw these disparities play out. Lots of people were already warning that they were going to happen, but we saw them play out in the first wave. And the response we got from government was to acknowledge the issues, that there are huge ethnic and racial disparities, but not to address them. They set up a commission, but commissions don't produce results for a crisis. And we saw a gap there. We saw this is a massive issue. These disparities are some of the starkest inequalities we've seen in recent times. Something's got to be done. Dismantling structural racism takes a concerted long-term effort, but you can create change in the short term to at least mitigate or reduce these inequalities. And that's what we were trying to do. So we came up with a proposal, a set of policies that could have been enacted pretty quickly. And you ask what's happened, I guess, in the meantime, as we enter the winter now. Unfortunately, the answer is very little. From a macro policy perspective, there are some really easy wins there that the government haven't really listened to. Their government published a report shortly after ours talking about what they were doing to to act on this. They picked up a few of our policies, such as funding more community COVID schemes. That's absolutely great. That's wonderful, but that's cherry picking really one bit of what is a much deeper problem. Speaking of healthcare, for example, we know that there are existing barriers to healthcare for Black and minority ethnic patients. We know that that's their long standing. Our research finds that when you look at A&E, Black patients were 50% more likely to need resuscitation in A&E when they got there. That's quite a whopping number. So what could be behind that? But roughly speaking, there are two things that could be there. Maybe once, so we're not talking about people getting an infection, which is socioeconomic determinants. We're talking about once you have an infection, why are you coming to more harm from it? It could be to do with underlying diseases like comorbidities. But what our research shows, and what loads of other people like the ONS have found too, is that comorbidities aren't explaining the disparities. They don't explain why Black and South Asian patients have worse outcomes from COVID, why they're more likely to end up in intensive care, why they're more likely to need resuscitation. So what else could be going on? Perhaps they're turning up to hospitals too late. This is when things like the hostile environment comes in. Public Health England did a report earlier this year, and they found the effect of the hostile environment creates a distrust between the citizen and the service. Sort of Black and South Asian people who have been targeted over years through this policy, this discriminatory policy, we're starting to see the effects of that. We've seen the effects of it for a long time, but in COVID, it's sort of right there in front of us. So one thing the government could do, for example, would be to at least stop charging during the course of the winter. That hasn't happened. And that's just one example. There's obviously more to delivering health than just the NHS. And there's a move and there's a shift to systems by default, working in systems, NHS working with local authorities, for example, to make sure that services can be delivered, social care services. So again, we can look at that and we can look at signs of what does structural racism mean? What does institutional racism mean? So we looked at the past 5 years in this piece of research. We found just over the past 5 years, the most ethnically diverse local authorities suffered over £15 million more in public health budget cuts. That is sort of in a nutshell what structural racism means. And we're seeing the effects of that now, but the causes are longer standing.
So Bhav summed up the kind of the actual research and the evidence that we produced. And I was just thinking about what Shahad was saying, that, you know, one of the great weapons that we have at our disposal is better data, better evidence. But what I have to say is, you know, despite having better data, better evidence, and also disaggregated by ethnicities, because remember, we are one of the few Western European countries that can actually collect data based on ethnicity. In many European countries, you can't do that. So one of the reasons why they say that they can't actually target policy focused on BME groups in the rest of Europe is that they can't collect that data. But the question that I've been asked, and I haven't been able to answer, is that despite having that data and that evidence, why hasn't the UK government targeted and protected BME groups from COVID, if we know that they are disproportionately impacted? And they're not just marginally impacted. Black men are twice as likely to be dying from COVID. Some groups are 3 times more likely. So despite having that data and that evidence, not just from ourselves, but many others, including the Institute of Fiscal Studies, I mean, how much more conservative can you get? The IFS saying the same thing as we are. And yet, despite that, as Parth was saying, government hasn't taken any action. Now, government continually says that we have taken action. By action, they mean more collection of data and evidence to look at more data to tell us what we already know, which is that we're dying at a greater number than our white counterparts. So I'm feeling incredibly frustrated at the lack of action. And in fact, just yesterday, I was on the news talking about the latest bit of evidence, you know, the biggest survey done, 18 million people surveyed. And again, the figures were the same. Black people are twice as likely to die. So I'm really a bit tired of hearing the data and evidence now. What I want to understand is, once you've got the data, it's actually quite easy to put forward some of the recommendations and solutions that we've suggested, much easier than looking for a vaccine, for example, right? Some of those solutions are, you know, providing isolation pay for people who are showing COVID symptoms. Some of those solutions are providing financial support so that somebody whose day job it is to drive a bus or an Uber doesn't feel compelled to go out and work if they still have COVID. Some of those solutions involve having to think about providing temporary accommodation for overcrowded housings where, say, Bangladeshis or other South Asians are living in multi-generational households. that isn't hard, it's not complex, but it does require a commitment from the government to transfer resources. And that's where I think, unless you see a shift in macroeconomic thinking towards managing a crisis and a pandemic and shifting resources for it, as opposed to macroeconomic policies that are designed to stimulate the economy, you will not see an impact on relieving stress on households experiencing crisis from COVID. So I remain incredibly concerned and worried that nothing has happened. And the other thing that is incredibly frustrating, and this isn't to do with COVID, if you go back to pre-COVID, a lot of the underlying reasons why Black and minority ethnic people suffer worse health outcomes are to do with inequalities, right? But what the government does continuously is what essentialize racial patterns across different groups. So for example, you would have heard a few months ago this whole conversation around, well, BME groups must be getting COVID because it's because of a lack of vitamin D, or it must be that they all have genetic conditions that allow them to become more vulnerable. I mean, all of that is nonsense. I mean, there might be a little bit of truth to it, but most of the reasons why we are vulnerable are external. We're overexposed and underprotected. And even to this day, we've just heard that government is apparently taking out a consultation on the lack of vitamin D, again in minority communities today. So instead of providing action and solutions, it just keeps going back to looking at essential factors to do with race that would somehow explain away why we are more vulnerable. I mean, simply it's eugenics and 19th century approach to managing health crises in our communities. It's got to stop.
And
I completely agree with both of my colleagues in terms of both, so the NHS and the equalities that have been, a light's been shone on, well, I suppose it's a huge light's been shone on, is actually is a reflection of the inequalities that exist already within our society for our communities. And I think that, so I would sort of probably bring in a little bit of a different angle before Path comes in. But I think there's something for me actually about the NHS being the biggest employer and also the biggest employer of Black staff who come from that community. And actually you've got an audience there who you can work with to think, to actually understand how you can build that trust and how the solutions may be developed and implemented. So even where the NHS have sought to act, so for example, if you take risk assessments, which is one of the ideas that came out, we should do risk assessments on BME staff, that actually how they were implemented has caused quite a lot of challenges. And there's also a thing for me, which we probably haven't touched on, is the NHS can also perpetuate or introduce new inequalities that probably didn't exist before through our policies and our decisions. So if you take the fact that the NHS has a policy around subcontracting, needs to go out to the market for agency staff, you also find that there was research in Leicester that there are higher numbers of BME staff within agency because they have a better experience or feel they have more control over their work than otherwise. But what we also found was during the first wave of the pandemic that it was the agency staff and it was the subcontracted staff who were being affected because they didn't have the same access to PPE. Mm-hmm. So, who provides PPE to the subcontracted staff? Is it the contractor? Is it the NHS? And actually, how do we ensure that worked?
I just wanted to come back onto Halima's point in terms of, because the question was about what's happened between the first wave and the second wave in terms of policy, really. And you can't fault the government for not talking about the issue. They've produced, PHE produced 2 reports. The Equalities Ministers produced a 60-page report on this. So they are looking at the issue and they're investigating why is it that minority ethnic people are suffering more from COVID. But what their reports are doing, and particularly the most recent one from the Equalities Minister, so it's government itself, is it makes the right findings, but then draws the wrong conclusions. And therefore the policy and the measures don't quite add up. And what I mean by that is they're saying what's driving these inequalities are structural differences in the jobs people do, structural differences in the conditions in which people live, structural differences in deprivation. That's what's behind this. But then their conclusion is somewhat non sequitur. They say, therefore, this is not structural racism, which is crazy. The 60-page report from the Equalities Minister doesn't mention the word racism once. And they say, well, it's all explained away by these statistical confounders, but I'm not sure living in a smaller house is a statistical confounder. We're talking about sort of behind the data of people's lives here. And therefore, when I say the measures don't quite match up, I mean, the policy is not really proportional to the scale of the problem or the causes of the problem. There's no policy on housing, as Lima said. Where temporary accommodation can work, something we've suggested. There are empty hotels around the country. It's sort of a win for the economy, a win for health, and a win for inequalities. But there's no talk about that. Even New York City are doing that, let alone the Asian countries. So there are obvious things that can be done, but there's maybe a lack of willingness to think about what would actually work versus what looks good in the optics.
So from my end, what has changed from from the beginning of the pandemic to now is unfortunately, I think, not a lot. If you look at the statistics, when this was first exposed, first week of April, what we highlighted was that over a third of patients in intensive care units came from a BAME background. Most recent figures show we're still, around that figure. We are seeing now that the frequency of, or the incidence of infection is twice as much in ethnic minority people compared to the white population. So I think that, as Salima said, I think there's a problem of overexposure to the virus coupled with underprotection. Now, I'll just look at just one thing that has changed, and I think that's about the only thing that I can think of has changed, is in the area of healthcare workers. So the doctors that I represent, we are now at least seeing risk assessments. So that's one change, that doctors are being risk assessed. But what our surveys have shown is that the risk assessment isn't a tick box. That's not an end in itself. It's what happens after the risk assessment. Have you then been redeployed? Have you been given a role that has understood your risk and put you out of harm's way? The NHS has many opportunities to protect healthcare workers. There's a lot of work in non-COVID areas. There's a lot of remote working. If you're a radiologist, you can easily read reports from home rather than be in a hospital environment. And what we've heard from the BMA is that those who have been risk assessed, the BAME doctors feel far less happy with the outcome of that risk assessment. So I think there's still the cultural issue that hasn't been addressed. The culture that healthcare workers work within has not itself just transformed overnight. But then, just looking more widely, what has the government done? I have to say I'm very disappointed. It commissioned a review in the second week of April when the stark disparities affecting the BAME community and healthcare workers was exposed. And the review was meant to come out by the end of May. Well, in fact, we had a review published at the beginning of June after it had actually been leaked. And then that review was a data analysis of information, a lot of which we knew before, such as ONS data. And it appeared there was a whole list of recommendations that hadn't been included in that publication. When that was actually published in the middle of June, and I will call that the Kevin Fenton report for want of a better word, that had 7 clear recommendations, very clear recommendations. Now, if you have a situation where a third of intensive care beds are occupied by BME people, and you've got the backdrop of hundreds of healthcare workers who've died from a BME background, you'd have thought that report would have been accompanied with an action plan and timescales. And we heard nothing. There was no public announcement by the government of how it was going to implement those 7 clear recommendations. And it took until October, 4 months later, that the Equalities Minister published her report. Now, what was also quite striking is that the Kevin Fenton report, the Public Health England report, was very clear about structural racism being a cause. I mean, it was fundamental to the recommendations. And what we heard from the Equalities Minister's report in October was didn't mention racism, and more importantly, it was a set of further data which was reinforcing what we knew, and some sort of aspirational, some recommendations of what needs to happen, but again with no timescales or a clear action plan. And so what we have at the moment is no no clear action that is visible in a consistent manner to address what is a continued situation where BAME communities and people are suffering disproportionately. And some of those recommendations were very, very easy in terms of to understand. One of the things that Public Health England said is you need to have culturally competent public health messaging. And remember, this is a virus that spreads because people are close to each other. They don't have the right protection. So the way you behave, the environment you exist in makes a huge difference. And what has also happened as a result of the pandemic and the Black Lives Matters movement is that there has been an element of mistrust between BAME communities and authority, you could say political authority. And what SAGE came out with in July was I thought, an insightful recommendation to government that public health messaging needs to be culturally competent, tailored. So it wasn't just about translating information, but they had even examples of how, posters which had the heading government poster wasn't going to be taken on board as compared to co-creating messaging with community leaders, and therefore communities own the messaging. And if you think about it, what does the rule of 6 mean to an overcrowded household? It doesn't. It's not culturally competent. Or if you look back at the pandemic and the lockdown, when the government and the Prime Minister said stay at home because that's where you'll be protected, what was the message for all of those key workers that couldn't stay at home but actually had to go out to work? What was the message of protection to them? Or the message, if you had someone with COVID in your own house, use a separate bathroom. What about the fact that, in deprived communities and large numbers of BAME communities, you don't have separate bathrooms for the person who has COVID? So we really have not had culturally competent messaging, and neither practical messaging. And also, when you look at the fact that messaging around even now, don't use public transport, don't go to work. Well, you know what? Large numbers of people who have to go to work, and even now we're staying at home, many are staying at home. People who are exposed are the key workers, and many of those are in insecure jobs. Many of those don't have the choice to be exposed. And you need to ask yourself, we talk about risk assessments. There's a difference between being in a healthcare sector and having an employer who can risk assess, nonetheless that the risk assessments need to be followed through. But what risk assessment is there for the BAME self-employed corner shop owner? Who's risk assessing that person? What if that person is 60 years old, of a Black background, with diabetes and hypertension? They're at high risk. Have they been protected? Have they even been given the messaging that you're at high risk? What I think that the government should be doing is reaching out to all of the community in that sense. Provide financial support for the adaptations that are needed for to protect people after risk assessments, and that should be self-declared risk assessments in these sorts of situations, and that may involve supporting them not to be exposed to the virus. It may mean also giving them protective equipment, because if they contract the virus, that is the risk we have in the health service. That's the intensive care beds that are being occupied. So there are a lot of things that could be done and should should already have been done. And I do feel that we need to be calling for action now. Obviously, we all know that the longer term structural inequalities aren't going to be changed overnight. We need to see a trajectory, but there are some things that really should and could be done now.
Thank you, Charles. I think Halima wants to come in.
The government has taken some action, I must admit, but it's all been focused on public messaging. Now, it's really important that we do not keep asking the government to improve on public messaging. I'll make it really simple for all of us to understand. My dad and his peer group in Tower Hamlets in East London are not at more risk because they don't understand public messaging. They're at more risk because once they understand the message and they have COVID symptoms, they do not know how to self-isolate. They don't have additional financial support. So I think the focus on public messaging was appropriate for the first few months, but fundamentally, we don't need more public messaging to understand how to be protected. We need practical measures around housing, an increase in isolation pay so that the Uber driver can actually stay at home when he or she has got COVID. These are very practical economic measures. And until we move away to practical economic measures, no amount of lockdown, no amount of public messaging is going to keep us safe. So you have to think about a zero COVID strategy as integrated and comprehensive. I am really frustrated at hearing more and more leaders calling for public messaging, because guess what? That's the one thing that government has done because it's the easiest thing to do. It's actually the cheapest intervention to make. And not only that, you can blame and shift the responsibility onto communities. Well, frankly, I understand the messages, but if I want to isolate and I live in an overcrowded housing, I need that option economically to move across. My local authority and my local mayor would like to support us, but he hasn't got the additional funding that local councils are dying for in order to provide temporary accommodation. It's very important that we don't let government off the hook. And frankly, you know, how many more reports do we need to see before more and more people die? So I would really urge us all to kind of move on from vitamin D, public health messaging, to action around putting where the money is. Put the money in front of local communities and their leaders, and they will know how to protect our communities better.
Thank you, Halima. I found it quite fascinating that hearing from Marie talk about agency staff, agency nursing staff facing a very different experience of accessing PPE, being able to speak out in the workplace. And then hearing Chand as well talking about medical staff and how their experience was very similar. And you can tell clearly that the disparity is in race rather than where or whereabouts you work in healthcare or the hierarchy within healthcare. Chand, I just wanted to ask a question around, you at the British Medical Association, you do a survey of doctors just to see the progress or the experience throughout the pandemic. What sort of things were highlighted in that, and has that sort of changed? And then a question, or just a comment, really, an observation that I made personally when you were talking about cultural competency around Eid time, when the government put Oldham into local lockdown. The community felt very much discriminated against, and then the government then announcing the second lockdown, which we're in currently, with the aim to work towards a Christmas where people can spend time with their family. And those subtle things where, you know, minority populations, like for example, it's Diwali tomorrow, and we're in a lockdown. You know, during Eid, large Muslim communities were in lockdown, yet for Christmas we're striving towards an environment, a time where a society where we're not in lockdown, where people can spend time with their family. And that those subtle messages or sort of proposals the government makes can lead to and does lead to mistrust between the government and minority communities. But yeah, that's just an observation I made. So Chand, do you want to go on to talk about some of the experiences doctors have faced and the things that you've noticed in the surveys that you've been doing over the past few months?
Yeah, so from the beginning of April, what we did at the British Medical Association is do what we call snapshot tracker surveys. We've done now 9 of them, and we surveyed our members about their experiences in the initial days. You know, it was very focused on PPE and testing, for example. It's changed over time. But one of the striking results with regards to our BAME, the doctors, was that in the height of when we didn't have enough PPE, you remember those days in March and early April when hospitals were literally running out of their last stock of PPE, where there was very clear rationing, and significant numbers of healthcare workers were seeing patients in non-COVID areas without any protection. And that was, of course, a misnomer, because those non-COVID areas did have COVID patients and an infection occurred. Well, in those days, and throughout the sort of first wave, 3 times, up to 3 times as many BAME doctors told us in the surveys that they felt under pressure to see patients without adequate PPE. And they also felt less protected throughout all of our surveys compared to their white counterparts. And when you go beneath those headlines, there are plenty of stories that I've come across from doctors I've spoken to, and it goes back to the environment before COVID, where we know that BAME doctors are twice as likely to not feel confident to raise even a patient safety concern, because when they do, they feel there's more likelihood that they will be blamed rather than the issue they raise being addressed. So what we found during the first wave was doctors who should have been protected didn't speak out. They didn't feel able to. They didn't feel able to challenge authority, and that clearly, is unacceptable. It's tragic, and we must make sure that this time round that doesn't happen. From the BMA's end, we set up a 24-hour member support line, because we felt that anyone at 2 a.m, if they were asked to see a patient without protection, they needed advocacy. So we even put forward that sort of support. More recently, the surveys continue to show difficulties that BAME doctors face. They've, during the COVID pandemic, have reported much higher levels of bullying and harassment. And remember, it's been a very tense time for all of us. So that sort of behaviour may even be more pronounced at a time when the health service is under so much pressure. And they also feel less confident now in able to cope, or rather they feel worried they won't be given the right protections moving forward to to what is now a second wave. So that's been very, that's been that's been the reports we've had in terms of risk assessments. The BAME doctors are reporting back to us probably about twice as many tell us they feel unsatisfied with their risk assessment, because of course the risk assessment is not an end in itself. It has to be a tool to result in change that protects the worker. And it's that second stage that BAME doctors are telling us in greater numbers that is not happening to their satisfaction.
Thank you. So just moving a little bit away from COVID-19 and the pandemic, just before this all kicked off, Chand and Marie, there was a lot going on in the medical or the healthcare environment around race and health. The British Medical Journal launched a special edition around racism. I think it was in February, where Chand was involved with that, and it was announced that the NHS Race and Health Observatory will be set up to focus on some of those issues. And Marie, you're chair of that organisation. I just wanted you to just tell us a little bit more about what the organisation does. Is it focused on healthcare workers, or is it race and health in general?
So it's thanks for the opportunity to explain. So the NHS Race and Health Observatory remit is in relation to health inequalities, but and although you can't address health inequalities without actually looking at leadership, so the two are intertwined, different faces of the same coin. What our remit to do is not just to observe, though. So it's actually is to gather evidence, but the emphasis is evidence on solutions, and from that evidence to provide really practical solutions, sort of things we've been talking about today, and work alongside the NHS, hold that mirror up, but then work alongside the NHS to help them implement those practical solutions, to explain there's ways to do that, how you can use regulation as a lever, for example, but again, to continue to hold that mirror up and say, well, yeah, in a more strident way, because of our independence, you haven't progressed enough, you haven't implemented enough, what is going on, for those recommendations. We've only been established since July. What we have done so far, we're just in the process to writing out to people who are going to be on our board. We have an academic steering group that is developing as well to sort of guide that work. And what we want to be is innovative and forward thinking. And we don't, what we've been having a conversation about is some of the responses are responses, maybe with intent, she said politely, that that are not helping to address the systemic racism our communities and our staff actually experience. And what we need to do now is move to a situation where there's no hiding space, where we have the evidence that backs up the practical solutions for action. We have actually agreed some priorities in conversation with our academic reference group. We had 100 academics in a room together, all taxing my brain, which was brilliant. But so the immediate recommendations that we've come up with are around COVID-19 and the impact on BME communities and what needs to happen now. The second area is around maternity. And a third, probably longer term area is around mental health. I think, it's one of the areas where you can really see those stark differences and, the grounding in terms of systemic racism. We're also going to interestingly look at the structure of the NHS, because what we found is every time the NHS changes its structure, which absolutely adores doing, the experiences of BME staff, whether it's in employment or in outcomes, suffers. So we know we're about to go through a restructuring. We know there's going to be more emphasis on system by default. It's not going to be a large bang like the 2012 Act. There's going to be a different way of doing things. And we want to ensure the observatory that change leads to improvement. And the long-term plan is really clear about the health inequalities it wants to address. And those are the right ones. And what we want to do as an observatory is make sure that in that implementation of that long-term plan, disparities based on race are not widened. Actually, that gap is reduced.
Brilliant. Go for it, Path.
I was saying that's really, really encouraging to hear, Marie. We're working on some research with the IPPR on delivering the long-term plan after COVID and thinking about explicitly making sure systems by default does reduce inequalities. So it's great. That's exactly where the Race and Health Observatory is looking to land its policies too. It's things like when we think about CCGs and commissioning services, we need to move away from the model that designs services for patients rather than with patients. Things like that. That place orientated approach is the way to tackle these inequalities, race inequalities, but also actually a lot of other inequalities. And Marie's absolutely right. It's health outcomes, 5 times increase, more likely to die at birth if you're Black. It's experience, the British Social Attitude Survey 2017, Black patients were the most likely to be unsatisfied with their experiences in the healthcare. And then there's the healthcare workers that Chand has spoken so eloquently about. So there's so many things here, but it is really about how the structures and the system within the NHS is organized. And as we shift, as we do this systems transformation, there's an opportunity here to explicitly make sure that the new system we move to is tackling inequalities. And that's great to hear that the NHS Race and Health Observatory is looking to fill that.
Thank you.
Who knows, Path, this could be the start of a beautiful collaboration between your two organizations.
Yeah.
I'll be in touch.
Definitely.
Halima, I've read quite a bit about the work that you do in your organization at the Runnymede Trust, mainly because you guys often publish work on the inequality in the British Bangladeshi community, a community that I come from myself. But in your experience, what in the research that your organization does, what have you noticed, or what do you think are the issues that lie in race and health in more general terms rather than in healthcare?
I think I just go back to that intersectionality between race and class a lot. And I think that explains a lot of outcomes rather than what has historically been the case from the health services. Say, well, these ethnic minority communities, they all have these outcomes because they all lack vitamin D, or they don't understand English, or there's something about the communities rather than the unequal structures of access and empowerment within local communities to services that create those outcomes. So it's really important that people can get their head around that, because if you can't get your head around that, then you can't apply the solution. So one of the reasons, I mean, I will break it down so that my mom and dad understand what it is I'm trying to say. So whenever I go to the GP, I go alone. I don't need anybody to come with me to access a GP. But when my father goes to the GP, he often needs me to attend with him, because he feels, even though he speaks English, the very fact that he looks like he's 80, the fact that he wears a Asian topi, and the fact that he looks vulnerable means that he's often overlooked and he's invisible when he shows up to the hospital or to a GP. GPs are really busy. They often don't stop to think about what it is and who it is that's trying to access their services. Over the years, my dad and other people like him will have experienced multiple examples of not being listened to, not being taken seriously, in fact, made to feel as though they're not well. And that repeats and repeats after 30 years, and they feel removed. They do not feel like the health services is equally accessed by people like them. And that is why you'll find that, you know, after years and years and years of that experience of feeling like the health services don't belong to them, that when they actually have COVID symptoms and they've showed up to their GPs, and when a nurse says, or somebody at hospital says, well, maybe you haven't got COVID, go home, they'll go home instead of standing there and demanding to be treated like I would. I feel very middle class at the moment. Whenever my rights are denied, I will bang on and on until somebody pays attention to my needs. But my father isn't the same. My father will sit there quietly, go back home, and he'll miss an opportunity to get treatment. This is what we mean by race and class, and how systemic inequalities arise. And that is what we need to pay attention to. The health services sadly don't seem to understand that inequalities arise from unequal access to services, and that needs to shift, and it isn't shifting fast enough. So I'd really, really like to see that. One thing I did want to say though, moving on from my particular experience, so I do like to talk about lived and learned experience as well. The Joint Committee report on human rights was published by the British Parliament yesterday. There were three very important messages there. The first message was that 75% of Black people have no confidence that either the Home Office or the police system or the health services protect their interests. Now, I found that quite damning. We've always known that the criminal justice system has not served justice very well for minorities. We've always known that. We've always known, I think, that the immigration service is hostile to minorities. What I don't think has been so well known is that Black people and minorities have a crisis of confidence in the NHS. Now, that to me is fundamentally a problem, because the NHS is staffed with higher numbers of minority workers than any other institution I can think of. And despite that, we seem to have a crisis of confidence in the NHS. What is going on there? I think it's systemic racism that is producing unequal outcomes for our minority communities. And we've got to deal with it as a systems issue rather than something about training doctors to be better aware or supporting my dad to be more empowered and so on. It's actually the system needing to be redesigned in a way that it's equitable. So that worries me a little bit, that, you know, the Joint Committee on Human Rights pretty much said there's systemic racism in 3 or 4 major institutions in this country where minorities come into contact with the state.
Thank you for that. Thank you for that comment, Halima. Go ahead, Chand.
I was just going to say that I think that there's no doubt there are structural factors that result in a very unequal inequalities in the medical profession. So even before you get to medical school, there is, as you know only too well, Jingy, because you've done work on this, there is not equal opportunities for students to get into medical school. There are certain EME groups that do not get into medical school. We have a gross underrepresentation of Black medical students and doctors. It's something that, as a BME doctor myself, I can say that there's not the same experience for all categories of different ethnicities, and there is gross underrepresentation of as I said, Black doctors and medical students, and we need to address that. When you get into medical school, there is now very clear evidence of increased bullying, harassment, and exclusion of medical students within medical schools. And that's an awful way to start your career in the National Health Service, to be trained as a doctor in a health service that is based upon, underpinned by values of equal and equality of care for all, that you should be experiencing unequal a treatment at the beginning of your training. When you then become a doctor, the evidence again is very clear that doctors from a BAME background are twice as likely to be referred for disciplinary processes. Now, when you then look at that more deeply, it's not because they're actually worse doctors. The General Medical Council have shown that it's to do with workplace bias, that you're more likely to be disciplined if you come from an ethnic minority background compared to white background. So there is bias in the workplace. We have something called differential attainment in the medical profession, which means that each stage of as you go up the career ladder, you have worse outcomes in terms of achievement, in terms of even exams of Black and ethnic minority doctors. And then when you look at the research around that, that's not because Black and ethnic minority doctors are not capable. It's not due to lack of ability. It's because of the systemic factors that have meant that they haven't been able to be included in learning, etc. Even small things, when you're a junior doctor in rotas, are you being involved in the same way? And we know learning is a social context as well. When you then look at the top of the medical ladder in terms of consultant posts, you are less likely to be shortlisted if you are from a Black and ethnic minority background, and you're less likely to be offered a consultant's post. So you've got more BAME doctors below the consultant grade and higher numbers in what's called the staff and associate specialist grade, which is a sub-consultant grade. So when you then go back to the COVID situation, I've been told by many that there was more front-facing roles of Black and ethnic minority doctors. The trouble is I can't answer that because I don't have the data. And so I think that there is still something about data, and we don't need data to prove racism. What we need data for is to intelligently understand what needs to happen to change. And data also is going to be a barometer to see whether there is going to be change, that the change has been delivered. And that's why I just want to say that I'm really sort of, I'm in awe of the three other contributors here with me today, because I think the Runnymede Trust, the IPPR have done fantastic research. And the data that's come from that research is not just numbers. They actually tell a story. They actually explain, and it's the intelligent understanding of how that information is used and how we make sure we go deeper into the structural factors that have led to those results, those statistical results that counts. And I want to say, Marie, I think that the Health and the NHS Race Observatory could not be coming at a better time. It was launched before COVID. It was launched in February. I was on the panel when it was announced at the BMJ event, and none of us knew then that racism was going to manifest itself through a virus in this way. And it could not have come at a better time. And what the Race Observatory, I think, it's important, is it's a repository of information to look at that information in an intelligent way. And make recommendations, but also the Race Observatory has the opportunity to commission research and data that is at the moment not there to actually support us to make policy changes that will really make a difference in the future.
I was just going to say, sort of pulling together sort of the three conversations the three things that have just been spoken, it's sort of, it comes back to that BMJ issue, and there's Professor David Williams is in there. He's sort of one of the biggest sort of academics in this field, and quite simply sort of spells out what is it about someone's race that then determines their health outcome. And there's two main pathways. The first is about your income, your occupation, your housing, these structural socioeconomic differences. And these are important. That is structural racism. But even when you account for all of those things, you're still at more risk from lots of conditions, COVID, but also various other conditions. So what's that other pathway that's going on? And that's where we think about things like healthcare access and prestige and access to institutions. And that I think that's important to remember too. So I guess what the role of the healthcare service is sort of in both, to be honest. The first one about actually making sure people are accessing healthcare services equally. But the second, as the NHS as an employer, as Marie says, it's a significant employer. It's an anchor institution. It's how it treats its workers. It has ways to modulate both of those pathways to try and stop race modulating health in the way it seems to at the moment.
Thank you, Parth. I think Chand and yourself have very nicely summarized the things we've spoken about today. We've sadly run out of time now. And I think it's been quite an interesting debate, or quite an interesting discussion between ourselves. Just touching on what you said, Parth, about David Williams, he talks a lot about empathy gap in the work that he does. And, having people, like Halima says, who have lived and learned experiences, talk about these things to go on to make, to go on to roles where you can influence policy. Chan talks about diversity as well in healthcare leadership. And again, that's some of the things that we do at the Healthcare Leadership Academy, is empower people from all walks of life, all different backgrounds, to then go on to take on these roles, so we can tackle these inequalities in society. I just want to say thank you so much to everyone for giving up their afternoon to talk to us and to discuss these very important issues. And in the Healthcare Leadership Academy, we have such a diverse cohort of people, not just scholars, but members of the faculty who come and teach and speak to our scholars as well, in the hope that one day we, as alumni and as scholars of the Healthcare Leadership Academy, will go on to make impact and changes in healthcare and in health in general, so that life is lived in a fairer and better society for all. Thank you again.